If we conclude that disc lesion is the likely diagnosis, traction is indicated for the lumbar spine, and if, indeed, traction causes relief, it confirms the diagnosis. If anteflexion is well tolerated, manual traction in flexion over our knees is carried out. The patient is supine on a low table or on a mat on the floor with his knees over the therapist's thigh, close to the knee. The therapist's foot is close to the patient's buttocks. The therapist presses the patient's leg close to his foot as a lever, lifting the buttocks free from the ground and making sure that they can swing freely. After this, he rhythmically increases and decreases his pressure on the patient's leg, affecting intermittent traction in flexion. If the patient's bent knee is exactly over the therapist's thigh, the lever is so powerful that the maneuver isn't tiring for the therapist, and the patient should feel relief. If extension is well tolerated, intermittent manual traction is indicated. The patient, prone, grasps the end of the table with his hands. The therapist stands at the other end and holds both feet above the ankles, which he must not squeeze. The therapist first makes sure that the patient is fully relaxed and then pulls the patient's feet slightly, letting them spring back. This is to find the individual springing rhythm of the patient. It must be felt not at the patient's hands, but in the low lumbar spine. The rhythm varies according to the height of the patient. This rhythm must be sensed by the therapist. Throughout the procedure, the patient should feel no pain, but if he does, we stop. We test whether he tolerates rhythmic traction of only one leg better. The procedure which is tolerated best is then used for treatment. Another method is isometric traction with the patient prone, his head at the edge of the table. The therapist stands in front of the patient's head with his hands on the iliac crests and buttocks. The slack is taken up by pressure from above and the patient is told, breathe out, and slowly breathe in. During exhalation, resistance increases owing to synkinetic contraction of the erector spinae. In the course of exhalation, we can also repeatedly press further. During inhalation, there's relaxation. The buttocks move in a caudal direction. If we have difficulty in reaching the patient's buttocks, we can stand at the side of the patient with our hands crossed, one hand against the thoracic spine, the other over his buttocks. Breathe out, and now breathe in slowly. Here we can see distraction taking place. And breathe out. During self-traction, the patient lies prone with the pelvis over the edge of the table. He starts with expiration, during which he lifts his buttocks. During deep inhalation, the buttocks drop, and relaxation and traction of the lumbar spine takes place. Breathe out and take a slow, deep breath in.